Córdoba, República Argentina. Con casi 3,5 millones de habitantes, somos la segunda provincia con mayor población de la Argentina. Estamos ubicados en el centro del país, tan cerca de los puertos del Atlántico como los del Pacífico, lo que nos ubica en un punto estratégico a nivel comercial, productivo y turístico. Ser mediterráneo no solo es un orgullo, también es un privilegio. Tenemos un ecosistema único donde conviven la montaña y el llano, los valles, las quebradas, las salinas y los ríos, generando una enorme diversidad natural que se complementa con un clima ideal de veranos cálidos e inviernos frescos que invitan a conocer y recorrer cada uno de sus rincones durante todas las estaciones del año. Y como nadie visita un lugar al que no puede llegar, comprendimos que a quienes nos visitan no solo hay que abrirles la puerta, sino que además hay que abrirles camino. Por eso, actualmente nuestra provincia posee el segundo hub aéreo más importante del país, una nueva puerta de entrada a la Argentina. Nuestro aeropuerto internacional nos conecta de forma directa con todo el país, Latinoamérica, Europa y Estados Unidos, a lo cual se suman los más de 100.000 kilómetros de autopistas, rutas y caminos que atraviesan y permiten llegar a cada una de nuestras bellezas naturales. Esta conectividad, junto a su variada infraestructura y servicios, convierten a Córdoba en un destino líder en turismo de reuniones, con más de 800 encuentros al año, siendo sede de mega eventos a nivel nacional e internacional. Contamos con el centro de convenciones más importante y moderno de la Argentina, con capacidad para 4.000 personas en auditorio, pabellones para exposición y múltiples salas para desarrollar todo tipo de eventos. Córdoba cuenta con una importante comunidad académica, profesional, científica y educativa, con 14 sedes universitarias, cuna de la Universidad Nacional de Córdoba, la segunda más antigua de América Latina, con más de 400 años de historia. La creatividad cordobesa, combinada con nuestras bellezas naturales y un valioso patrimonio cultural, posibilita crear experiencias únicas e incentivos posibles de disfrutar durante todo el año. Este desarrollo de la actividad es resultado del trabajo conjunto entre los sectores público y privado, con profesionales de gran experiencia y la trayectoria de más de 10 años del Córdoba Convention and Visitors Bureau como aliado estratégico para potenciar la industria de reuniones. Sierras, ríos, lagos, lagunas, campos de golf, aventura, exquisitos sabores, caminos del vino, patrimonio cultural y religioso, fiestas y festivales, teatros, centros de divertimento. En definitiva, somos una nueva forma de descubrir la Argentina. Presente e historia. raíces y futuro. Bienvenidos a Córdoba.
காஃபி போடுமா? இரு நீ சொல்றா இதா.
For all the people, if you could be so kind to mute the microphone till the very end of the conference, it would be greatly appreciated. Thank you.
Well, Dr. Jerónimo, I think you can start.
Okay, thank you. Hello and welcome to everybody. Today, we are going to talk about chronic mechanical irritation in oral cancer. On this regard, it is important to note that when we are saying oral cancer, we are referring precisely to oral squamous cell carcinoma. First and foremost, sorry? Okay.
No.
I will continue. First and foremost, we would like to express our gratitude to the authorities of our institution, Professor Actis and Professor Fontanetti, and particularly to Professor Saman Guarnacolosudilla for his priceless guidance and support. So, let's get to it, shall we? Okay, today I'm going to show you a broad view of what we are about to discuss, from how the topic came to be, how to identify it, and some key topics on CMI and oral cancer. Well, the hypothesis that chronic trauma could be linked to OC is not new. In the 19th century, Martin et al. Have suggested this association, already stating that the ubiquity of the so-called dental factors. So, tobacco, betel quid, and alcohol consumption are major risk factors for oral cancer. However, they could not cause the totality of cancers. And also, there are individuals unexposed to those that develop malignant lesions. Thus, there has to be another risk factors for OC. And we believe that chronic mechanical irritation, CMI, could be one of those. So, the first published studies that we've been able to track began in 1940 with Martin. And those studies dealing with the relationship between trauma and OC were mainly experts' opinions and case reports. In the first half of the 20th century, irritation produced by teeth or dentures was already considered as a potential cause for OC, mainly in the tongue. This was followed by other papers, but for many years, the available evidence was on this very same basic level. It was not until the 2000s that the research began to take proper shape. So, the third question we would like to ask, what is CMI? What is considered CMI? Mechanical irritation was first known as trauma. Chronic mechanical irritation, as we prefer to call it, refers to the repetitive harmful action on the oral mucosa produced by a mechanical agent. From our point of view, the criteria for CMI identification has 3 parts, and they all have to be found. First, we have to find an objective clinical lesion compatible with mechanical origin. And it has to be of over a month of evolution for it to be considered chronic. It should be duly noted that we are here referring to a long-standing and continuous action, not the occasional accident or accidental bite. Sorry. Second, the mechanical injury agent should be in the oral cavity before the onset of the lesion to fulfill the temporality principle, which is first came the cause, the mechanical agent, and then the lesion. Yes? Third, the traumatic agent must be in direct contact with the lesion. In this context, a broken or defective teeth or denture does not equal a CMI lesion. One is a factor and the other is the consequence. So, mechanical irritation could directly produce a wide array of lesions that you can see on the left of the screen. Within this group, we believe that chronic traumatic ulcer, CTU, could be the lesion more related with malignant transformation. On the other hand, mechanical irritation could also modify pre-existing diseases, changing their evolution, such as oral potentially malignant disorders like leukoplakia and oral lichen planus. Well, as you probably know, not all CMI lesions, however, are created equal. CMI effects could range from a moderate, mild epithelial response to a more evident tissue injury, like an ulcer. Only the ones that produce both a persistent hyperproliferative status and chronic inflammation could be related to carcinogenesis, in our opinion. So, to be crystal clear about this, we do not believe that each and every one of the CMI lesions could develop cancer, only the one that has these particular features. Well, we classify the mechanical irritation factors, the factors that are able to produce such lesion, in 3 groups. Fixed factors, previously referred as dental factors, the ones that could not be taken off by the patient, removable or prosthetic factors, and last, functional factors. The latter offers feasibility, increasing contact frequency and strength. This could explain, in our opinion, why not all patients that has a potentially harmful mechanical factor indeed develop lesions. Therefore, functional factors might enable the persistence of a mechanical injury. Regarding localization of Cmi lesions, almost half of them are located on the lateral border of the tongue. And here, they are usually related to fixed or dental factors. In contrast, buccal mucosa lesions are mostly explained by removable factors. Both chronic traumatic ulcer and oral squamous cell carcinoma show preference on the border of the tongue and buccal mucosa, which is slightly different from the sites affected for the rest of the benign irritative mechanical lesions. Well, the Cmi factor occurrence, which factor is present, was similar in all three groups when comparing benign irritative mechanical lesions, chronic traumatic ulcer, and oral cancer. The percentage are maybe the same, it's close enough. The most common is dental factors, but the high frequency of functional factors, it amounts to a total of 75%, suggests that they are of great relevance too. One thing, the numbers in this graphic do not add up to 100% because in most cases, the factors act in a joint combined fashion. So the very same patient could have, in some cases, all three factors producing the injury. Well, we can see that oral cancer had a longer time of exposition to the mechanical factor with a mean of 49 months, which could suggest a dose-effect relationship. Also, removable factors show a longer time span in all groups with a statistically significant It could be because fixed factors, dental factors, are not modifiable by the patient, thus acting without interruption. If you compare that with removable factors, it could be easily discontinued. Its action could be ceased by the patient easily. Well, here to show you a clinical case of oral cancer associated to chronic mechanical irritation. This particular patient was a non-drinker and non-smoker and presented a squamous cell carcinoma on the border of the tongue. The inverted overbite and teeth malposition made the patient unintentionally bite chew the area of the lesion for more than 3 years. So, if you can remember, we have all the conditions. Lesion has over a month, the injuring factor was present before the onset, and we have a direct contact. Here we have another case of a heavy drinker, never smoker. The lesion of the border of the tongue was in direct contact to Cmi because teeth malposition and also a defective denture, both in direct contact with the area for more than 4 years. Well, now delving directly into the epidemiological evidence, although currently there is limited evidence, this meta-analysis by Cmi et al. Supports the relationship between Cmi and oral cancer, especially regarding to ill-fitting dentures. Well, another cross-sectional study by Piemonte et al. Also revealed a statistical significant association between CMI and OC. In this work, all three types of CMI factors, fixed, removable, and functional, were recorded. The oral cancer group had a lot more CMI, which here is depicted in red color. Later on, another study, in this case a case control study, further validated this statistical association, despite the high CMI occurrence in the control group. Again, the difference between CMI occurrences was statistically significant. Remarkably, and this is for the same study, the statistical significance for CMI was maintained in the multivariate analysis, adjusted for age, gender, tobacco, and alcohol. Based on the same study, the relation between tumor size and CMI occurrence was assessed. And there were no statistical significant difference regarding to tumor size. As you can see, the columns here, the occurrence was presented no significant difference. This fact suggests that CMI is not a consequence of cancer of tumor growth and could be found even in initial stages or lesions that are quite small. Well, moving on to animal studies, although there is not much of them, they evenly show an association between chronic mechanical irritation
so if you look at
and the sorry, there is an audio. Okay, I will follow up. I was saying that regarding animal studies, they evenly show that an association between chronic mechanical irritation and OSCC. Among them, I want to highlight especially the work by Perez et al. This study shows clearly the relevance of CMI in the malignant transformation process. Take a quick look at the table presented here. In which cases there was not cancer? Each row represents a group. If you can see the second and fourth groups, when there was only mechanical irritation or DMBA3 as initiator, there was not cancer. On the other hand, when CMI was added after DMBA3, CMI defined tumor site, reduce the latency period, and generate more aggressive tumors, more endophytic tumors. So this is useful to understand how this could be the role of CMI in the oral carcinogenesis process. Well, in 2010, we proposed a theoretical model of the potential pathways for CMI in oral carcinogenesis. We believe that CMI could act in several stages of the malignant transformation process, but mainly inducing cellular proliferation through different and various mechanisms and chronic inflammation. And something that we have just recently, it could ease HPV penetration and activation. Well, speaking of the possible, the potential biological mechanisms involved to malignant transformation of CMI, here we can see that on the CTU, the chronic traumatic ulcer borders, there was a CK5-6 positivity throughout the whole epithelium, not just the basal layer, which suggests presence of immature cells in the more external layers, which could enhance HPV penetration. Also, moreover, the suprabasal expression of CK19 that we found on the epithelium borders of CTU are similar to those found in high-grade dysplasias. So, we now have two very important mechanisms on how CMI could act promoting carcinogenesis. The current evidence suggests that chronic trauma may act mainly as promoter, as tumor promoter. Probably it is non-mutagenic and its effect could be reversible. In order to prove that, its effect should be found even in early stages of malignant transformation associated perhaps to tobacco, alcohol, or some other factors. One molecular pathway that have all those features is DNA hypermethylation. Well, here I am showing you the results of one work when we use a split mount design to compare the effect of chronic mechanical irritation on the methylation status of both P16 and MGAT, which are two well-known tumor suppressor genes. One sample was taken, as you can see, on the right side of the ventral tongue, of the borders of the CTU. And the culture was taken from the very same patient from a clinically healthy mucosa. So we found effectively more hypermethylation of both MGMT and P16 on sites affected by chronic mechanical irritation with CTU than in mucosa devoid of mechanical irritation. Hypermethylation of both of these tumor suppressor genes could lead to genetic silencing, which in turn could contribute to the malignant transformation capability of CMI. Another study from people from our group shows that telomerase activity in oral cancer, oral potentially malignant disorder, and normal mucosa was indeed increased when CMI was present. What's more, not only its presence was found more with CMI, but its intensity. Increased telomerase activity could lead to an unlimited replication potential. Well, to round up the current evidence, using as a basis table the key features of, according to the International Association for Research on Cancer, is CMI a carcinogen? Could be considered. If you can see here, is xenotoxic? It's probable. We have a study, very recent study that shows that chronic mechanical irritation produces more micronuclei. Also, CMI induce genomic instability because of what we talk about hypermethylation on MGMT. Consequently, it also induce epigenetic alterations. It can produce oxidative stress. Also, and this is maybe the one fact that everyone is agreeing about, it does indeed produce chronic inflammation. It could induce immunosuppression through pro-inflammatory mediators and accumulation of or activation of immune suppressor cells. Also, as we have said, could improve HPV penetration, could produce cell immortalization by the increased telomerase activity. At last, it alters cell proliferation by increasing Ki67 activity. Well, to talk about the limitations that the CMI research encompasses, it's just not feasible to do follow-up studies like cohort studies, like the ones that are common to use to prove the malignant transformation of another oral potentially malignant disorders such as leukoplakia, because traumatic lesions usually resolve with simple, fast, and safe procedures. So there is no possibility to do follow-up studies because they will need to leave these lesions untreated, which would be unethical and dangerous, which leaves us with animal experiments, and there's still a limited amount of original studies on it. So another particular problem that we found in CMI research is, as an example, we could mention that chronic traumatic ulcer, as we say, has been proposed as a type of oral potentially malignant disorder. But most of the chronic traumatic ulcers have less than 2 centimeters long in presentation, whereas at global level, more than 50% of the oral cancers are diagnosed in size far greater than 2 centimeters. So, if indeed a CTU could be a precursor lesion of oral cancer, it is likely that when malignancy is identified, the tumor growth have completely changed the clinical aspect of the disease. Well, what could be the general dental practitioner role? So the clinical relevance is, for the general practitioner and also for the specialist, is to identify, treat, and control patients who have CMI. Briefly, the JDP could have a relevant role in not only preventing malignant transformation, but when properly treating CMI, it could prove unnecessary to perform another methods. Especially if a traumatic lesion heals only with easy, simple methods. Furthermore, what's more important, in individuals in patients with other oral potentially malignant disorders, proper treatment of the mechanical injury factors, fixed, removable, and functional, could be an important measure to reduce the risk of oral cancer. In this particular slide, we have a before to the left and after, and the only treatment applied here was the removal of the mechanical irritation using soft splits, as you can see in the photo. So, rounding up, all things considered, the evidence available so far does not allow to fully prove the relationship between CMI and oral cancer. The epidemiological evidence is still somehow insufficient, and the biological process involved are not clarified just yet. But we now have clear guidelines as to how to properly address the research. And it has to be said that there are no high evidence studies that refute this association. Indeed, there are more that support it. So, how the research between CMI and oral cancer could be improved? By doing epidemiological studies with a careful methodology and recording with great level of detail all factors, because remember, all three factors, the fixed, removable, and functional, could be present in the very same patients. Yes. Also, to do more biomolecular studies, and of course, pre and post treatment studies of CMI alone and acting on previous diseases such as oral potentially malignant disorders. Paraphrasing Professor Aguirre, if you can convince them, at least create some confusion. Call it the seed of a doubt, a scientific curiosity.
It was quite interesting to see some of the publications.
So, finally, I want to leave you with the following question.
Di tempat gituannya. Ini sini. Itu nggak ada.
How many of your
Itu apa? Coba cari.
cases are healthy and complete
Coba balik dong.
with mental health, free of malpositions, functional habits? Do you have this data? If you do, if you can answer this question in full and compare the oral cancer group with a control group, you are surely able to contribute scientific evidence to analyze the relationship between chronic mechanical irritation and oral cancer. Well, thank you all. And I am now taking questions.
Habis kenapa? Sama tiduran kah? Apa gimana?
Set of studies in 5 countries had increased their use, and another study conducted in
Di Indonesia disebut kenapa ya?
set of workers had increased their use of the product. I also want to mention.
Okay, now I'm now trying to see the the chat to read some questions, if you have some. Okay. Hello. Thank you all. We are overwhelmed by the massive turnout that we have. Well, I'm reading. If some of you want to talk out loud your question, please unmute yourself and go on. But by now, I'm going to read some of the questions. Dr. Saman, hi, Professor. Ask, has HPV been detected at the base of the CMI ulcer? We have some initial results. This particular line of research is led by Dr. Gilligan, but we have some research that shows using PCR and P16 positivity using immunohistochemistry of HPV on such traumatic lesions, particularly chronic traumatic ulcer.
Thank you very much.
How are you? I hope my English was not that that bad.
Excellent.
Okay. Doctor, I will try to pronounce this right, but Dr. Joy Tap, sorry if I'm not saying it wrong, asked if can we take interleukin 4 as marker? Well, as actually the next part of our research on the topic is aimed at study chronic inflammation using several factors. We have fought on several of pro-inflammatory factors, nuclear factor kappa B, for example. Okay. Markers. Well, to round up, the other molecular markers that we have been studied, that I mentioned, just to quote the note, Ki67, CK and CK19, the hypermethylation status of both NGMT and P16. Well, okay, Dr. Adeline Saroja asks if any diagnostic markers that can be implemented in CMI to diagnose oral cancer or its progression to oral cancer. Well, as you may probably know, doctor, that's a very good question. I think that would be the question of the $1 million mark. But sadly, there is no single or even a group of molecular markers that could predict 100% sure which chronic traumatic ulcer or which CMI lesions will eventually transform. If you can maybe believe in a part, we believe that every of these chronic mechanical irritation lesion that could induce a persistent, continuous chronic inflammation, both chronic inflammation and proliferative status, could be the ones that end up maybe developing cancer in particular patients. Well, Dr. Shoitap thinks that our definition for CMI criteria was awesome. Thank you, dear professor. We are by no means we believe that the definition that we propose is complete, but it allows us to be more objective in research to properly identify which conditions should be met when speaking in absence or presence of CMI. Well, Dr. Radica asked, can P63 or P53 be used to assess the epithelium? Thank you, Dr. Radica. Yes, indeed. We have some few cases where we test with immunohistochemistry the P53 status, but we are still gathering some more cases because it's a kind of a costly method to use. But yes, that's one of the markers that we would really love to see.
Dr. Geronimo?
Yes?
Just to add your answer, we are looking for some biomarkers such as P53, cyclin D1, and BCL2 on the edges of the chronic traumatic ulcers. We are working on that issue now. Sorry.
Oh, yes, thank you. Dr. Iligan is one of our group. We work together. Well, Dr. Rajev, excuse me if I'm not pronouncing it right, asked, even after the removal of the offending factor, can the initial lesion aggravate? Well, if such lesion is only produced by a mechanical factor, it should be fully or almost fully resolved if you remove the injuring factor. However, if another lesion or even the malignant transformation process has begun, the healing could not be that accurate, and in which case we usually, as I'm sure all of you do, if we remove the mechanical factor, injuring factor that we believe is causing the lesion, and 2 to 3 weeks, and the lesion does not resolve itself, we perform a biopsy. Yes. Well, Dr. Mandarasi say from Indonesia, hi, ask, do you suggest to follow up every patient with CMI for detection for oral cancer? That's a very good question, doctor. We believe that CMI could be thought as a risk factor for oral cancer. Now, we are not saying that it is indeed in all of the cases, or even is the most important factor. No. But we are saying that it should be considered when assessing the particular risk of an individual for oral cancer. It should be taken into account with as much detail as tobacco and alcohol consumption. Recording evolution period, recording all the factors, the combination of them, not only denture or dental, but all of them. If you remember, more than 75% of the CMI lesions, whatever it may be the group, in oral cancer, in oral potentially malignant disorder, and in the so-called benign irritative mechanical lesions, the amount of functional factor was the same. And we believe that functional factors is the key to develop mechanical lesions. I'm pretty sure that in your clinic, you may see a lot of patients with defective teeth with malposition, maybe even with sharp edges, with dentures that maybe are also defective. But when you see, when you perform an exam, you don't find any lesion. Why is that? We believe that precisely the functional factor plays a key role in developing and maintaining the contact and the strength, which might actually develop a mechanical lesion. And I'm hoping that that is clear enough. Dr. Ashishi, sorry again. Among those patients where there is a coexistence of tobacco, arecanut, or CMI, is there a possibility of difference in nature from progression of cancer? Dr. Ashish from Nepal. Oh, hello. Well, Dr. Ashishi, yes, indeed. If you remember the animal study that I showed of Perez et al. that I highly recommend if you have the time to give it a look. The presence of CMI in a patient who has already a mutation, an initiated cell, could shorten the latency period. So the malignant lesions could develop in a shorter period of time. Second, it can define the site of tumor size, of the tumor growth. And also, the lesions associated with chronic mechanical irritation are of worse grade of malignancy, because are endophytic lesions that could produce infiltration, metastasis early on. Actually, there's at least 2 studies that shows that in oral cancer patients, the presence of chronic mechanical irritation can worsen the prognostic, the 5-year prognostic, and the presence of metastasis, no metastasis. Well, if I'm talking too fast, please let me know. Dr. Melanie Kargani, hi. She's curious if in all the cases you have research on where CMI is associated with oral squamous cell carcinoma, were there co-existing risk factors such as smoking and alcohol drinking? Well, that's indeed a very good question. The current evidence does not position CMI as in the role of initiation. It can hardly produce DNA mutations. A recent study that I quote shows that although it can produce more micronuclei, that it is somehow related to genotoxicity. But in the context of the multifactorial process that is oral carcinogenesis, we believe that in the cases where CMI is present and the patient has another factors, remember this, we do not know what all the factors are. We have some very strong evidence to link alcohol and tobacco consumption, but not all oral cancers are related to tobacco and alcohol consumptions, and there are cancers in patients unexposed to those factors, and even betel quid. So I'm pretty sure that there are a lot of other factors what we may yet not know. We are just proposing that CMI should be considered as one of them, as one risk factor for oral cancer. Well, I'm hoping that answers your question. Thank you. Thank you, Dr. Ashish. Well, Dr. Radica says that they found some correlation in oral potentially malignant disorder with this marker. I believe, Dr. Radica, that you refer to MGMT and P16 hypermethylation or some other. Well, I'll leave you to it. Oh, yes, we have no direct experience from betel quid, and we believe that betel quid chewing could act producing mechanical irritation, but we just do not know. This is an idea that we have. We have some people in the audience that I believe that work with that, so we would like to hear your ideas about that. Oh, Dr. Arpan Shah says that they have observed few cases of oral squamous cell carcinoma arising due to chronic mechanical irritation, where almost all patients were suffering from diabetes mellitus. Okay. Also, those tumors were less invasive histologically. So, is there any relation between CMI, diabetes, and occurrence of OSCC? Well, we do not have studies to back it up, but one well-renowned oral medicine specialist, Dr. Grispan, who has a very extensive textbook on oral medicine, mentioned diabetes as a predisposing factor to mechanical lesions, particularly to chronic traumatic ulcer. It can be said, again, I do not have evidence, but it can be said safely, I believe, that any condition that hampers physiological cicatrization, that alters healing in some way, could help develop a mechanical injury lesion. Yes, but okay. Dr. Alka-Kale asked, how do we clinically differentiate between reactive hyperplasia to CMI-induced oral squamous cell carcinoma? Dr. Alka for India. Dr. Alka, that is indeed another of the $1 million questions. In 2019, the past year, we have a discussion with Dr. The name has, the Harvard health professor, Dr. And Hera, could you remind me, please? The name has just vanished from me.
Suk
Bingu, Dr. Suk Bingu. Thank you, Gerardo. Dr. Suk Bingu, who asked precisely about that. She believed that the ATPs and the dysplasias found in the chronic traumatic ulcer are the type of, she calls, reactive ATP, reactive dysplasia. With that, she conveys that dysplasia could be reversible and therefore is not important for malignant transformation. But to that, we posit this situation. Okay, let's suppose that ATP or dysplasia is indeed reactive and reversible. But what happens if in a particular patient that reactive dysplasia is allowed to linger on by weeks, months, and even years? It could easily produce a malignant transformation. If you add to that the proper environment created by chronic inflammation, I would say that you have a very good possibility, you have good chances that a malignant transformation could arise from the hyperplasia produced by chronic traumatic irritation. Okay, Dr. Suganya asked is there any stromal marker to assess tumor microenvironment? Oh, we are not yet at that level. We are now focused on studying mostly epithelial process, but as I mentioned before, our idea is to continue to study chronic inflammation, and we will use a variety of markers to see just that, tumor microenvironment, and how could CMI enhance the malignant transformation process.
Dr. Lazos,
yes.
We have, regarding your last answer, we have found more reactive dysplasia or more reactive changes on those ulcers located on the lateral border than in other parts of the oral mucosa. So the ventrolateral tongue is really a high area of development of oral squamous cell carcinoma.
Okay, thank you. As you can see, this is a joint effort. No one can achieve this kind of work alone. Dr. Okay. R.B. Bonkan, I'm sorry, ask, hi, there is any specific area where with the higher predilection in the mouth for mechanical irritation of where oral cancer can arise? Dr. Bonkan from the Philippines. How? The Philippines. Okay. Dr. Bonkan, that is a very good question. The two main sites affected by chronic mechanical irritation both in relation to oral cancer and when acting over some pre-existing oral potentially malignant disorder are mainly lateral border of the tongue and buccal mucosa, because those are the places where it can be injured by fixed or declinal factors. When we are talking about denture, a defective denture, or a denture-related irritation, it may be buccal mucosa, but more closely to the mucobusal fold, and sometimes even in the floor of the mouth. Those are I would say, the preferred locations for malignant transformation of a CTU lesion. Well, Dr. Panta, Dr. Panta, hi, that's an old friend also. Dr. Panta says that he really appreciates our work. Well, thank you, Dr. Panta. You are really, really kind to us. Your work is really good also. It's underestimated. Well, we are trying to give it, to expose it to the world, to discuss it. Dr. Ashish, this is a very informative session. Thank you, thank you. Well, Dr. Desiana Raditya from Indonesia. Oh, hello. Do you think the tendency to malignant transformation of CMI lesion is associated with the hereditary history of cancer? There is no current evidence that strongly backs this relationship with hereditary history. We have seen in some of our patients some background with a story of cancer from another site, an oral cancer, but the evidence is nowhere near conclusive about that. In that particular aspect, we share the most of the author view on that. There's no evidence to back that up completely. Oh, thank you, Dr. Morgante. Well, Dr. Ashish says, okay, yes, that conducting a prospective study might be ethically impossible. Yes, of course. So what type of study research do you suggest to reconsider CMI as one of the risk factor for oral cancer? Dr. Ashish from Nepal. Wait, maybe I say it too fast, but yes, since follow-up studies are obviously cannot be done, we propose some studies. The most obvious one are animal studies, laboratory studies, where you can control most of the variables that you wish to study. But when going to the clinic side, working on patients, we believe that follow-up studies using an invasive procedure like exfoliative cytology. For example, you take a leukoplakia, an oral lichen planus with CMI, and that CMI, it may be the cause of that lesions to have more redness, to even have erosions. You do one cytology then, and you wait 2 weeks, and you control it to measure maybe chronic inflammation, some biomarkers. For example, the hypermethylation work that I showed you was done using exfoliative cytology. Most of the studies of epigenetic alterations in oral cancer uses biopsy. So one of the technical aspect that we propose is that another is to use what's called the split mouth design that is very common in periodontology. See? So in that model, you have one part of the mouth, let's say the right side, with CMI, and you have as control, you can use as control the contralateral side without CMI. Since using our criteria, you can objectively define, you can say, here we have CMI because we have a lesion, we have a factor, and they are in contact. And when you see a clinical healthy mucosa, you can say, here we do not have CMI. You can use the same patient as control, therefore reaching the best variable equalization. When you do a pair study, you use patients about the same age with pretty much the same risk factor, but they are equal, not the same. Using the split mouth design, you can use that. It has to be said that one of the exclusion criteria that we use when studying CMI is that when we are studying CMI effect alone, the patient should not have any other oral potential malignant disorder in the oral cavity, because we know that patients with oral lichen planus, with leukoplakia, have what it is called field cancerization. So if you want to study chronic mechanical irritation effects per se, you leave oral potential disorders out, and of course oral cancer. I hope that that answers your question, Dr. Ashish. Okay. Well, EEBOOB2. Dr. Renuga. Sorry, Dr. Renuga from India. Hi, sir. In patients with sharp tip and no associated clinical presentation, I am assuming that you refer to a clinical lesion. Does nuclear abnormalities like micronuclei, nuclear bulbs, and nuclear bridge represent the damage caused by the mechanical irritation? Okay. The study on micronuclei was from very recent. It has, I think, that less than a month. Is just hot, just coming out of the oven. But we believe that the CMI could be able to produce some molecular changes, but to say that those possible molecular changes could be induced before we see a lesion clinically, I don't know, but I would say that is not likely, because unlike, let's just say, tobacco consumption that could produce a field cancerization, even if you do not have clinical lesions associated to it, chronic mechanical irritation, by our definition, has to be present with a lesion. That's the way to say, to a certain point, here we have CMI, here we don't. Okay. Oh, well, thank you for all the people that is expressing they like our presentation. Well, Dr. Saman, hello. Here we have a good one. Could CMI be a cofactor in chronic alcoholics? Has that been studied? Well, we we believe that I am going to approach the subject broadly. We believe that CMI could be a cofactor in pretty much every known risk factor, or even in a patient that has no discernible factor, but could, for example, have a mutation, a P53 DNA mutation, let's say, or some molecular alteration that is not yet studied. But yes, we have some patients that were never smokers and have alcohol consumption, and they develop lesions when the only risk factor that you can find on them was alcoholic consumption and nothing else. We do have that, not that many cases, but patients where no known risk factors, only with the CMI factor identification that develop oral cancer. But how that came to be, we still need a long way to answer that properly. Have I responded? Haven't been relatively clear, let's just say. Thank you for all of you. Excuse me, because I know that my English is not as good as it should be. Dr. Piemonte, oh, wow. The Associate Professor of our Oral Medicine Department, Dr. Piemonte, who is the author of many of the work that I have shown you, say that is a more epidemiological and biomolecular research is needed to clearly identify the several interactions between CMI and other factors. One of the problems with CMI study research as a risk factor, because you have a lot of co-founders to take into account in the same patients. Because some authors post that when you have a patient that have a bad oral health in general, with bleeding gums, with periodontal disease, with maybe one or more teeth that have been lost due to caries, to cavities or periodontal disease, you have a lot of conditions that could somehow produce or improve malignant transformation, and it is difficult to separate the CMI effect alone. But this, again, we believe that that could be properly studied using the split mouth designs and recording with as much detail as tobacco on alcohol consumption CMI. The factor, the type of factor, the exposition time, well, that. Thank you, Doctora Gracia, Dr. Nisha. Okay, Dr. Gilligan, Dr. Piemonte, Dr. Guarnacruzilla, if I'm missing some question, but I believe that I have come to answer all of them, maybe? If someone wishes to... yes, please.
Dr. Lopez de Blanc want to say that also dental factors, CMIs, are more frequent in alcoholic patients.
Yes. Well, in closing, I really want to say again, to express our deepest gratitude to Dr. Saman Guarnacruzilla for his continuous guidance and support throughout all the years that we know each other. He has been a tremendous help and continues to be. This massive turnout that we have, it couldn't be possible if not for him making this little webinar known to the world. and that not just an expression, to the world. Thank you, Dr. Saman, again.
Excellent lecture, excellent.
Thank you, thank you. Well, I'm hoping that you find that this webinar useful. We are ready for any other question that you might want to send us to the mail, or if you think that maybe some particular topic, it could be, I don't know, we could delve more deeply into some of the topics that they presented, please let us know, and we could arrange some other webinar maybe where more of us talk about our ideas on the topic. We will love that. Thank you, thank you. Gerardo, Dr. Piemonte, Dr. Saman, does someone want to say something before we go on? We say goodbye. Hi.
Goodbye. Thank you, everyone.
Thank you.
Well,
Thank you.
Our deepest, big thank you for all of you for endure my not so clear English. Thank you. See you the next one. And take care of yourselves. Bye-bye.
Bye-bye. Bye.
Secretaría de Presidencia. Buenos días. ¿Alguna novedad?